Good evening, everyone. For those who are coming into our webinar on advanced courses, on behalf of the European Resuscitation Council, a very warm welcome to every one of you, and thanks for making time to I will give everyone the time to join, and we will start by 8 p.m. sharp in order to maximize the hour we have. In the meanwhile, you will see appearing the program for tonight on your screen, as well as some basic rules. I will go over these rules a number of times to make sure that everyone understands how to ask questions. You can ask questions through the Q&A at the bottom of your Zoom screen. You can also send questions even later on to our webinar at erc.edu address. And the questions that cannot be answered during this webinar will be answered on the FAQ page of our COVID web page. So not every question will be answered or can be answered during this webinar given the limited time we have, but we'll make sure that everyone gets answered in a number of time. So still a lot of people joining us, already 205 participants. Welcome everyone. Okay, and by now it's 8 o'clock, so I suggest that we move on. A number of people will be popping in later on. Once again, a very warm welcome on behalf of the European Resuscitation Council. I'm very happy to host you on our first webinar on advanced courses. To establish the rules, you will be able to ask questions through the Q&A. We will do our best to answer most questions tonight, or at least most important and recurring questions. For the questions that we're not able to answer tonight, we will provide you an answer through the Q&A or to our FAQ landing page on the COVID website. We will talk about advanced courses, and I'm happy to host a number of experts in the field, and we will consecutively talk about neonatal life support. John Madar, very welcome. We will have basic life support in, advanced life support in children, my mistake, Patrick van der Voorde, welcome Patrick. And we will talk about advanced life support in adults. Carsten Lott, very welcome. Our experts will briefly give you a presentation summarizing the guidelines, the COVID guidelines. And afterwards, we will go into a panel discussion, and we will address how to safely restart those advanced courses and try to answer most of your questions. But before we move on to the presentations, I would like to welcome our chairman, Jerry Nolan, and hand over to him for a short introduction. Good evening, Jerry.
Good evening. Thank you very much indeed, Nicholas, and welcome everybody to this webinar. This is the second of two that we've run this evening. I'm going to share my screen, hopefully, so that you can see my slides. First of all, I'd like to thank Nicolas, Helene and Olivier, who've done a lot of work behind the scenes putting this all together, and thanks also to the speakers that you're going to hear later on. I hope you will find this helpful. I don't need to tell you all that we are really in the midst, to some extent, of a serious world global crisis, this pandemic, COVID-19. And it's affected all of our lives, whether we're healthcare workers or not. And of course, it's really started in China. Probably the timing is not exactly known, but certainly towards the end of December, when the first cases were known about. And a number of things came out early out of this. We recognized it was potentially a serious disease, affecting, of course, not just patients, but healthcare workers as well. And this picture on the right here is the Dr. Li Wang-Chiang, who was really first to alert the world to the potential problem of COVID-19. And sadly, it took his own life. This screenshot that I took just this morning just gives you an idea of where we are now. Although, of course, we're slowly coming out of lockdown within most of Europe, of course, we're still really in the midst of the global pandemic, with cases rising fairly rapidly, as you can see, sitting now at a total of about 7.5 million. How's that affected us from the resuscitation side? Well, clearly it's had an enormous impact on cardiac arrest training for resuscitation. And one of the first things that happened when this disease arrived in Europe, which was probably around the 20th of February, with the first cases in northern Italy. And we've been hearing from a previous seminar from Federico Semeraro, who works up in that region in Italy. It's pretty quickly spread over the rest of Europe. And from that time, there were a number of reasons why we were unable to undertake resuscitation training, both basic and advanced courses. Number one, of course, a lot of the people that were involved in doing that training had to be diverted to save lives and divert to other clinical areas. And secondly, of course, there was the potential risk of transmission of this disease amongst those healthcare workers who were involved in training. So for a variety of reasons, including those two, the courses pretty well had to cease. Now, you will hear this evening that we're beginning to emerge from that now, and courses are beginning to run. And I think the real challenge that we face is trying to balance the risk and benefit of both cardiac arrest and resuscitation in terms of saving lives of somebody in cardiac arrest, but minimizing the risk to the healthcare provider. And to some extent, that's true also in training, of course. We want to train people, but we don't want to put them at risk during that training. And that applies both to the public and healthcare providers. We believe at the ERC, and you'll hear details about this in a moment, that we are at a stage where we think we can restart training to a variety of participants at minimal risk to both them and the instructors undertaking it. And you'll get some practical tips on how we can do that soon. And that will hopefully bring us towards a return to what you've obviously heard many times before, the so-called new normal, because we probably will never go back to exactly as we were before. I've got a final slide here just to say that this paper, which is an executive summary of the ERC COVID-19 guidelines, has just gone online recently. Those guidelines are available in full on the ERC website, and they include some of the guidance around delivery of resuscitation that you'll hear about shortly, but importantly also cover the ways that we can deliver resuscitation training safely. And with that, I will hand over to my colleagues.
Thank you, Jerry, for this introduction and for being with us tonight. In the meanwhile, I also want to introduce Tino Greif, who joined us and who is our Director Training and Education. Tino will join us later on and participate in our panel discussion on how to restart courses. Well, welcome, Tino. So before we start with the presentations and the resumes of the COVID guidelines for each course type, I would like to ask our audience to participate in a poll in order to see who is attending our webinar. And you will see that the poll is appearing right now. I would just ask you for your background and on which course type you regularly teach. So I give you a couple of minutes to answer those two questions. And in the meanwhile, I'll take the opportunity just to remember that you can send us your questions through the Q&A in the Zoom or directly via webinar@erc.edu if you would be looking at this webinar in a delayed time. So we are already at 50% answers. Just give you a couple of more seconds to answer the poll. Seems once again that we have a lot of our instructors present. I already saw that we have hellos from all over the world. It's a pleasure to see that our community takes time to be with us and to follow our activities. Welcome once again to everyone on behalf of the European Resuscitation Council. So we have 70% of answers, and I think we can just leave a few more seconds and then we will close the poll and show the answers to everyone. Okay, so we have almost 75% of people who answered. I guess you can see the results. We have a lot of instructors, course directors present, also a number of other sympathizants, and not surprisingly are most of the people teaching in advanced life support, but I'm happy to see that also a lot of basic life support instructors are present. Thanks for being here. We will move on and I will hand over to our first speaker, who is John Madar, and who will talk about COVID guidelines in neonatal life support. Welcome, John.
Thanks, Nicholas. I hope you can hear me. If you can't, I apologise, but not a lot I can do about that. So talk briefly about newborn life support and hopefully provide a little bit of background on how the guidelines have changed. So hopefully you can see my screen. NLS in the COVID era. So as you may know or have realised from reading literature and guidelines, from the newborn life support perspective, the guidelines have not substantially changed from those before COVID. And most of the recommendations are around the protection and reduction of cross-infection. So the actual published algorithm is very much the same as previously, with one or two highlighted areas which relate to the potential for COVID infection. And what I'll do briefly is just cover each of these in turn. So the indications for the attendance of the neonatal team in advance and the factors which might prompt a resuscitation remain unchanged. We know from the evidence we've got that the risk of vertical transmission to the baby at birth is actually very low. And there's really no significant incidence of COVID-19 infection in newborn babies at birth, even when the mother has proven or suspected COVID-19. So this is a reassuring feature, which means that newborn babies as a rule are not affected, and COVID-19 in the mother does not appear to adversely affect the baby at birth, although delivery may be influenced by the fact that mum has COVID-19. As far as the actual sequence of assessment and then the practical approach to the resuscitation of the baby, it's unchanged and it follows the standard principles of newborn life support. There are changes, and those changes reflect precautions taken to reduce cross-infection for both staff and for the baby. So in the first instance, team briefing and equipment checks should be undertaken as previously. Obviously, considering the matter of PPE, there may be a little bit more consideration given to the makeup of the team, trying to minimise the number of people attending the delivery, but making sure they have sufficient expertise to undertake any of the relevant procedures which might be required. That team may choose to wait or may attend in person in the same room as the mother or be elsewhere. Some people have advocated the use of a partition to make the resuscitation area physically separate from that of the mum. Others have advocated resuscitating the baby in a room immediately adjacent to where mum is delivered. As far as PPE is concerned, aerosol precaution PPE is recommended because it's not possible to be sure that there will not be any airway generating procedures undertaken during the resuscitation. The first actions are unchanged. There's no change to the initial approach to the baby at birth and no change to the assessment. Cord clamping is recommended as it has been previously. Obviously, care needs to be taken with materials used at birth, and the towel in which the baby is wrapped initially may be contaminated with maternal secretions and blood, and therefore has to be considered a potential infection risk and needs to be dealt with accordingly. During the course of the resuscitation, the sequence of actions is unchanged, with airway opening maneuvers followed by inflation breaths, and the only caveat that is placed is that of consideration to a viral filter or an HME between the mask and the bag valve or the T-piece. It's not a mandatory feature. The vertical transmission rate is very low. The expectation of infection in the baby is low, but mask inflation is considered an airway generating procedure in other age groups. As far as the practicalities of viral filters are concerned, care needs to be taken here because there are filters and their volumes and their tidal volumes are limited, and therefore they may not be suitable for all babies. So it's important to make sure that if one is used, it's not compromising the ventilation in any way. Following a resuscitation, if the baby is well, it may be given back to mum. If the baby needs transfer to a neonatal unit, then it's recommended that a closed incubator is used for transfer to reduce the possibility of infection during the transit. And as far as the staff accompanying that baby are concerned, consideration needs to be given to the PPE that they are wearing. And if it's expected that intervention might be needed during transit from resuscitation to the baby unit, then they may need to consider wearing droplet protection or airborne protection PPE rather, as opposed to droplet protection PPE. And if so, this would be different PPE to that used in the delivery area, as they are going out into uncontaminated areas. If interventions are undertaken between the resuscitation area and the newborn unit, then it would be better to try and avoid airway generated procedures in outside the controlled areas. In the case of a baby who is already born, i.e. in the post-resuscitation and in the postnatal situation, there are certain considerations that need to be borne in mind. The COVID status of the mother may be unknown, the COVID status of the baby may be unknown. Resuscitation should still take place in the designated resuscitation area, and again, standard newborn life support principles apply. It's recommended that PPE is used for all resuscitations, but the immediate staff who are there at the time of collapse may not be in full airborne protection PPE, but just droplet protection PPE. If a team is summoned to a postnatal resuscitation, it's recommended that they use airborne protection PPE, and that may incur a delay while they get into their protection. Care needs to be taken during resuscitation, and decisions on providing breathing support in the absence of full airborne precaution PPE need to be made, understanding there may be a small but undefined risk of COVID-19 exposure. So in summary, the likelihood of infection at birth is low, but is a consideration in the postnatal situation. There is no change to the basic approach to newborn life support, and the precautions are those around the potential to reduce cross-infection. So thanks for your attention, and we'll cover the issues relating to the newborn life support course in the forum afterwards.
Thank you very much, John, for this clear summary of the COVID guidelines in neonatal life support. We will move further on to Patrick van der Voorde, who will talk about advanced life support in children. Good evening, Patrick.
Hi, this is second time, and it's now about advanced life support, and in a way people should have been in the basic as well, because of course it's a continuum where you need both in a way. And I won't pick up again what I've said in the previous one, but the video is there, so you can always watch. Now, part of my slides are very similar though. It's important to understand that the incidence of COVID-19 in children is low, and that children are also low spreaders. That's become clear in literature by now. There are children that will get ill, and there are children that will get ill very severely, but majority of critically ill children have other causes. And it's a balance. And that's been said by other speakers, by Jerry as well. We need to find that balance, because obviously there is a risk for the rescuer, and we should keep that risk low. But there's an even bigger risk if we do not do proper medicine for all those critically ill children. And there's always been a risk to our profession, and we should not stop doing things to save children. Obviously, this will depend country by country and region by region to know what is this real balance. And when we wrote our guidelines, it was very difficult to really clarify for which population they were actually meant, because obviously we use terms like suspected or proven. Obviously proven, then you know both for sure, or those where you cannot rule out COVID, which is a far larger population, but with an incidence that is probably very, very low. And depending on where you are, might have to decide, will I use airborne precaution for every action I do, or will I use droplet precaution, and which are the additional measures that I can do to protect the rescuer and still try to save the child. And this is actually what we also try to do in our guidelines, find that balance. And it's clear for the critically ill child that although there are a lot of other cases, there's no sign that can help you to identify COVID in that child. So we put a lot of emphasis in our pediatric courses on recognition, on treating the critically ill child, because eventually most of the cardiac arrest is a secondary nature. And if we are able to identify and treat the child beforehand, then we can avoid even being in cardiac arrest. So we already had this hands-off observational assessment. This is definitely a strong tool in these situations where you look at behavior, breathing, and bodily color. But if needed, if something is wrong, you still have to go to ABCD, and you still, in a lot of children, will have to do aerosol generating procedures. Healthcare professionals are people that should always have the access to full protective measures, meaning airborne protection equipment. And ideally, for every child where you cannot rule out COVID, you should be wearing this. Of course, there is that balance, and we would say that if you only have droplet protection, then probably airway maintenance, giving oxygen, or even giving high flow nasal cannula, in that group of persons where it is not really suspected, would be possible. Importantly is the fact that you do it, and that you equally do back mask ventilation and consider airway and breathing management of the utmost priority, because otherwise you will get into cardiac arrest. And once that cardiac arrest is identified, we join with the adult guidelines in a way that, and with the neonatal ones, that normally spoken, you should be wearing, as a healthcare professional doing advanced life support, you should be wearing full airborne protection, even if it causes a little delay. Of course, the better your protocols are as a team, the less delay you will have. And once you are fully protected, there's no reason where you should make any change to your 2015 algorithms. Initially, there was a lot of, not pressure, but a lot of literature pointing towards, or consensus pointing towards, early invasive airway, but this also has risk. And it's definitely sure that ventilations by back mask, especially if done by a two-person technique, are are equally valid also for CPR in children. And then I'll already, before the discussion, go a bit on restarting training, instructor-led training. Again, you have the unknown risk of COVID, then it's between two persons who do not have any symptoms but are both attending the course. And we should definitely keep all rules of social distancing. But we also know that advanced life support saves lives by definition, and that you cannot only train virtually. You will have to do instructor-led training. So I think we'll come back to that, but this is clearly the moment to restart training. And how to do this is definitely just by teaching the 2015 protocol. There are, especially in basic life support for children, some small adaptations. There's still that emphasis on ventilation, but you'll need to think about optimal course duration. Maybe these are smaller courses because of keeping this social distancing. And you'll have to have a context that is as safe as possible without hampering what we really want to do. And what we really want to do is retrain people and save lives. It's a way to go, but the future is there.
Thank you very much, Patrick. Thank you for stressing as well, Patrick, that the people who were not able to attend our first webinar on basic courses will be able to look at the webinar. We will put it on our YouTube channel and on our Facebook and ERC webpage as well, for the BLS the basic courses as for the advanced courses. And we'll move on to our next speaker, who is Carsten Lott. Welcome, Carsten, and good evening. And Carsten will talk about advanced life support in adults.
Yes, so good evening, everybody. My name is Carsten Lott, and I am kind of sharing the educational part of the Science Education Committee and Advanced Life Support. I'm just going to share my screen, so now you should see my slides. My part is Advanced Life Support. So I'm covering the group that has a somewhat higher infection risk than the neonates or the pediatric patients we've been talking about as far. I'm going to talk you through advanced life support and immediate life support, and I will start with the guidelines as well, and then get you some ideas on how to modify courses or how to run courses during the pandemic. So comparable to the pediatric part and the neonatal part, we have taken the advanced life support algorithm and have adapted some changes to that. And this is the main part of my talk, to get you an idea about these changes and the rationale behind the changes. As you can clearly see from that modified algorithm, there are three parts where we applied changes. First and most important bit, and this is where I disagree slightly with Patrick, is the safety issue. I think this is the most important bit. Safety first is important during that pandemic period. And in the advanced life support guidelines, we published a safety statement on that, and that clearly indicates that it's never acceptable to compromise the safety of healthcare professionals when providing resuscitation measures in patients. And the safety priorities should be safety for yourself, followed by safety for colleagues and bystanders, and then safety for the patient. We've already been talking about droplets and about airborne particles. Looking at the adult part, we are dealing with airborne particles that might carry the infection. So the minimum PPE we need for adult resuscitation is the airborne precaution PPE. This includes gloves, long-sleeved gowns, filtering face pieces, grade 3, or if not available, FFP2 masks, and the full eye and face protection for the provider. ILCOR provided some guidance that formed the basis for our adult guidelines, and I picked up the 3 most important bits for advanced life support. And this is a statement that chest compressions and cardiopulmonary resuscitation clearly have the potential to generate aerosols. And in the current COVID-19 pandemic, healthcare professionals should be called on that use PPE for aerosol-generating procedures. There's one exception, and that exception is about defibrillation. Defibrillation is not an airborne particle-generating procedure, so defibrillation might be possible wearing only droplet precaution or while the team is donning the PPE themselves. You can start the patient on defibrillation. So this followed up with the ERC guidelines, and in our ERC guidelines on COVID-19, we recommended to have some kind of an early decision-making process in your patients. So it should become clear pretty soon when you start your resuscitation efforts if the patient is going to benefit from your resuscitation measures or if he does not, and then decisions are to be made a bit earlier than we had that in our former algorithms. PPE must be available, even if that causes a delay to start chest compressions, and this is a clear difference to what we taught as far. As far, we always thought that we need to start chest compressions as soon as possible, but now, as we know, it's an airborne particle generating procedure. We need to take time to put on our PPE before we start chest compressions and before we do any kind of airway management in our adult patient. Once we start ventilation in our patients, we should use viral filters, and as defibrillation is unlikely to be that aerosol generating procedure, defibrillation can be performed first before getting in the whole process. And this leads to the following algorithm changes. BLS has already been covered in the sessions before. We will not recommend chest compressions or airway interventions without airborne precaution PPE. You can use defibrillation as an intermediate measure. So if your defibrillator is immediately available, you can provide up to 3 shocks to allow donning of the PPE for the rest of the team. As John already said, the number of staff members needs to be clearly restricted, not to get too many staff members in contact with the patient. In our trainings, it has been a good idea to allocate some kind of gatekeeper who's kind of regulating the access to the patient. As long as the bag for ventilation is available, you should place an oxygen mask over face, over mouth and nose of the patient and provide oxygen that way, and then start your chest compressions. Once you get into ventilation, use viral filters for ventilation. Try to minimize the need for manual ventilations, and if you do so, use a 2-person technique to guarantee the seal of the mask. Try to get into your airway management procedures as early as possible. You should have experienced staff for that. If available, use a video laryngoscope to get some distance from the patient, and you should only switch to continuous chest compressions in the adult setting if you placed an endotracheal tube in your patient. If you have a prolonged resuscitation, you should consider mechanical CPR in the prolonged cases. Then we need to talk about the prone position. It might easily happen that you need to resuscitate the patient in the ICU setting that is in prone position. Here we recommend to start compression between the scapulae. You can use the usual depth and the usual rate. But you need to take in mind that you eventually need to turn your patient supine if your compressions are ineffective. You can monitor that via your capnography or via the arterial line that's usually in place in that patient. You need to turn your patient if interventions are needed, like airway management interventions, or if the circulation does not become restored within minutes. And you need to keep in mind that you need to think about alternative defibrillation spots. And this might be the anterior-posterior position in your patients or the biaxillary approach in your patients. Finally, don't forget, because this is what we already learned from Ebola, it's important to doff your PPE as safe as possible. We recommend using kind of a buddy approach, so to connect team members to control one each other while doffing the PPE to avoid self-contamination. And as in usual resuscitations, team debrief is pretty important to get an idea of what you did and how you can improve. Last but most important, This is not what we are used to, and this is why we feel that it's that important to practice and to train what you do. We already did in my course center in Germany one ALS course, and we learned during that course that it's pretty important to train how to don and how to doff your PPE, and to train how to use your technical skills and your non-technical skills using your PPE. Especially communication is totally changed, and this is where you need courses for. This is our program we started in my course center. As you can see, there's some changes in the session at the start. We added PPE to get all participants an idea how to use PPE, how to don, how to doff it. And then we used PPE throughout the whole course. So all resuscitation practice and the mannequin was done using PPE for everybody involved in the whole setting. We allocated gatekeepers and all that stuff to give them an idea how to handle that. And in the ALS part on day 2, we included prone position, resus in prone position during the special circumstances session, to get them some more ideas on how to handle these kind of patients and to get some practice on that. And work in progress, we are about to develop a one-day program for regions where the local regional restrictions do not allow for 2-day courses. This is our draft program, and we are about to finalize all the e-learning stuff that's needed beside that to get a full immediate life support, advanced life support course. We will hopefully have the first pilot courses in July that year. Thanks for your attention, and I'm happy to get your questions.
Thank you very much, Carsten, for your summary. Before we go to the panel discussion and try to answer some questions or some more questions, I would like to pop up a new poll just to see in which or to which extent our audience estimates that by now they have sufficient information to safely restart courses in their country. And in addition, did you already restart courses in your country? And we will ask you exactly the 2 same questions by the end of the panel discussion. And well, hopefully we'll be able to see a difference and have been able to attend most of your concerns. So I'll give you a couple of seconds. And in the meanwhile, I see that still a lot of questions are filtering through the Q&A. We're at almost 70% of the people answering the poll. I think we can close that right now and show the results. Well, 60% estimates that he or she has enough information to safely restart courses, and only 24% of the people answering the poll already restarted courses in their country. Now, it's important with regard to the safe restart of the courses. We are aware that the restart of the courses and the use of PPE will largely depend on local recommendations as well. So we will come back to that. I already saw a number of questions regarding PPEs and regarding to local regulation. But I will first ask to our panel, why should we start or restart our courses already now? Why is that so important, even during this post-pandemic period where we still don't know where we are heading to? Why is it important for you, that we already restart to teach by now? Maybe Tino.
Why it's important? We have data how many people will die if CPR and advanced life support is not executed. We have a lot of studies are now out that less people are coming to the emergency room with cardiac with infarction, stroke, surgery in some difficult and emergency areas was going down, and we can save about 300 persons in 100,000 inhabitants by applying CPR. And other calculations come up with maybe one rescuer infected, and he or she might be die also in 100,000. So there's a downside, but we need to restart our courses to train people, and specifically in the application of the precautions for COVID-19. If not, people will get infected and people will suffer from cardiac arrest without our help. That's the most important thing.
Okay, that's a very clear answer. Carsten, you want to add something to that?
Yeah, sure. So we made some experience 3 weeks ago when we did our first advanced life support course during that pandemic. And the evaluation clearly indicated that people think it's necessary to practice that context and to do it as a team training. And this is what we teach in our adult courses. Our adult courses focus on team training. And now we can train the teams under that specific conditions of the pandemic. So people think it's important, and otherwise I fully agree to Tino. Cardiac arrests will occur anyway, and we will additionally need to learn how to handle suspected COVID cases in that setting.
Okay, thank you, Carsten. One major observation to that is that, well, in order to restart training, we have to do it in a safe way. How would you recommend to organize the training with PPE? Which PPE should be used? A number of people made the remark that, well, due to shortage of PPE in some countries, there are no PPEs left for training. How would you respond to that?
So if I can share my screen for a second again, I'm going to show you a picture. So this is how we did it. That picture was made. And as you can see, we used some kind of protection that is not useful in real medical cases. So this is kind of a gown we use that can be washed and can be reused. We used standard face shields, for sure we did, but we have sufficient amounts of that, and we use standard gloves for that. So we tried not to use resources that are needed for medical management, but nevertheless, we felt it is pretty important to practice donning and doffing of that as part of the measures and management of the patients.
Okay, thank you, Carsten. Yes, of course, we're fully aware that there are alternatives to PPEs in order to simulate them. Another question asked by one of our attendees is the fact that, well, maybe even in this pandemic period, it's even more important to train and to regularly train people in the skills, which is not always possible. How would you recommend with regard to the retraining periods, the certificate periods? Anyone who wants to answer that?
What exactly was your question?
Well, the question is with regard to the retraining, that a yearly retraining is not possible for every healthcare provider during this post-pandemic period. And the question is if that's judicious, because regular training is important.
So for advanced life support, this is simple to answer, because I think this should be the same for the pediatric advanced life support bits, because we have an online course, and our recertification strategy means that you need to kind of come to a hands-on course once every 2 years, and that you need to do an online training the other year. This online training focusing on COVID is available, so it's easy to recertify at the moment.
Mm-hmm. Now, and obviously there might be, especially in pediatric in some countries, with courses restarting, for some people it might be difficult to get this 2-year approach, but that's why one of the reasons why we need to restart courses. And there will definitely be a bit of flexibility, but you have to know that skills and knowledge will decline, and this will impact how performance is in reality. And that's one of the reasons to now really restart with courses is to serve the public and change practice. And also, it might also impact on the fear of some people of doing things. It's you need to do it in a proper way, but definitely number one is you need to do it still and not stand aside.
Exactly. John, you also want to add something.
So there's the matter of delivering formal courses such as NLS and EPALS and ALS. And along with that is the tied responsibility for any organization to maintain the teaching in-house, which is at a different level, but it is equally vital and important in maintaining the skills, because we know that there is a decrease in competency over time. So both elements need to be addressed, the formal courses and the certification, but also in-house training and ongoing professional development. And the needs in terms of the organization for that and for the PPE used and everything else are slightly different, but the two are inextricably linked. So we need to be working along both those tracks.
Mm-hmm.
Okay, with regard...
Maybe, Nicolas, maybe something just
Yes.
is that these needs are international, but obviously the rules and regulations might differ between countries or even regional, your hospital, and eventually you'll also have to follow your local rules. That's what is reality now. If these local rules are very different of what it should be, then there's need for advocacy by ERC, but also by you yourself and your organization to just try and change and optimize that you can really restart that training or do proper CPR.
Okay, another question with regard to the courses. A number of people ask what is the ideal amount or the maximum amount of people we can allow on a course. And the second question in addition to that, should people be screened before they come to the course in comparison with patients admitted at the hospital for surgery who undergo a pre-screening? How are you feeling about that?
The group size, I would say everything up to 6 persons is fine. This depends mostly on the space in your facility. If you have enough space for this social distancing, so people can stand apart 1 or 2 meters, fine. If you have smaller rooms, then you might have only courses with 4 people in a group, in one group. This depends mostly on this part. And pre-testing is, again, if you have all this equipment and the test kits, it could be a possibility. But at the moment, it's a clear no, because nobody has these facilities. And I would like much more test suspected infections, people out there, and not course participants. And then is also the question, who is going to pay this? So at the moment, I don't see any way of testing people beforehand, except in a couple of months or maybe in a year. They are very, very cheap tests, and this is a normal procedure for everybody. Okay. And if this is a fear, then you can't do it. But I don't see this as a fear, because as a healthcare provider attending an advanced life support course, this is part of our job. We are confronted with infection diseases, and we have the measures. We wear masks, we wear gloves, eye protection, and that's it. What's the problem?
And during our job, we actually already interact with tens and tens of people only wearing surgical masks.
Yeah.
Without feeling that as a difficulty to do. So because there was a question, should we turn our ALS course into a hazmat course? And that's obviously no. It's just that what's been said is on the one hand, you have to be safe but reasonable. And in a normal social contact, surgical masks and hand hygiene is enough. But obviously what is also said is that during training, doing at least a few, if not all scenarios in food protection brings it closer to the reality of what you should do in an actual CPR as well, which is probably the better training.
Yeah, to add to that, since we had to work in full PPE during our advanced life support course due to our hospital authorities, because providing chest compressions might kind of generate airborne particles as well. If one of the candidates is infected, then this candidate is pretty close to the other ones working at the mannequin. And this is why our hospital authorities kind of told us that we cannot run courses without using the full PPE.
Okay. In order to maybe reduce the risk during hands-on courses, well, one of our Greek colleagues asked the question, how can we create a hybrid course, making use of the advantages of online learning by doing, for example, the multiple choice test online. Anyone who wants, maybe Carsten, did you already try this out, making a hybrid program with a part online and then a modified hands-on part?
Yeah, sure. So this has been the last slide I've shown you in my presentation. This was the one-day course, and that one-day course will have the MCQ as an online version.
Mm-hmm.
Yeah, okay, thank you.
Maybe Nicolas, just to say, because I think moving forward to having this preparation online, and we have the cozy e-learning environment that can really be very helpful. The one day is a minimum, but what we felt with the ePulse course organizers and course directors, that having the availability of doing this hands-on part is still obviously also very important. And I couldn't convince any of the pediatric course directors to move to the one day with preparation. They all stayed with the 2 days for the courses that they are now going to be run. But still, obviously, and we'll try to enforce it more and more in the future, that we have a strong e-learning platform by COSI so that people can properly prepare.
Okay, thank you, Patrick. We're moving ahead in time as well, but there is a last major question I would like to ask you, because it's a concern among participants regarding intubation. Number of people ask, well, are we advocating that intubation or early intubation should be the gold standard during this pandemic period? Anyone who wants to comment on that?
So as I raised that, and this is part of the added guidelines, endotracheal intubation has always been the gold standard for managing that kind of patient. But, and this is a big but, and this does not change under pandemic conditions, you need an experienced provider to perform endotracheal intubation. Within our advanced life support courses, we will not be able to kind of generate competency in doing endotracheal intubation. So we can only mention it, but we cannot practice it to an extent that our providers will be able to perform endotracheal intubation in a resus patient when getting out and managing patients. So it is gold standard, but it needs an experienced provider to perform it. And if you do not have that experienced provider as part of your team, as part of your resource team, then you need to go for alternative measures.
Okay, thank you.
That's even more so in children, I think, where, well, or equally so in children at least, where airway management is even more difficult, and proper oxygenation and ventilation is even more important. So unless you're very trained, we would stick with the back mask ventilation in a two-person approach. Of course, if you're well trained, you can move to intubation with a cuff tube then. And when the ETT is in, you probably could go to continuous compressions with asynchronous ventilation. But the standard is definitely not to move fast forward to intubation. That's definitely not.
Okay. I'm aware that we're not able to answer every question, but I want to repeat that all guidances are available in a Pathway to Resume Courses document that is online on the website. You can download it for free. With the summer in advance, there is one last question that comes back, and then we already discussed that in the basic courses session. It's with regard to drowning, both in adult and children. What are the recommendations for drowning and resuscitation of drowning?
So the question was from a specific country where they say there's a lot of family members present. So if family members or close relatives are there, they are living with the person they rescued from the pool or wherever they get the victim out. I don't see this as a problem for doing then mouth-to-mouth ventilation, but in a patient in this situation, ventilation is essential. And if there's no mask there, and this will be very rare, then you have to do mouth-to-mouth ventilation. And if you don't want, then the only thing is chest compression only. For the professional rescuers at the beaches, we might think in the future to train them also in mask back ventilation. This might be a change for all these people who have a duty to respond on beaches or swimming pools or whatever.
Thank you, Tino. Patrick or John, you want to add anything to that?
No, I completely agree. There's national laws and regulations, but sometimes we then need advocacy from our part to change these regulations. And for these with a duty to respond, and in situations where, like children or drowning, where ventilation really makes a difference, these professionals, which are first responders, and that's a difficult group to catch, they should be protected as much as possible, also be able to use tools that really make a difference, like back mask. And that's why we're talking also always of these two-person approaches, because it's an easier and safer way to perform back mask in a CPR setting. This is not the case in a non-CPR setting sometimes, but in the CPR setting, this is probably the way to go forward. And that's a way that you should be able to teach to a much larger group than only physicians or nurses.
Okay. Thank you, everyone. I will, before we let you give a take-home message to our participants, I will ask to put up the poll once more, and to ask you once again, well, after this webinar, do you feel you have enough information to now safely restart courses? And will you restart courses in your country? Of course, taking into account local regulations, as we said. Give you a couple of seconds to answer to that, and I take the opportunity to repeat that our free ERC COSI online learning is available. You will find teaching on all COVID-19 guidelines on our COSI platform for free. All documents with the guidelines are on our website, as well the Resuming Courses pathway. The slides and the presentation will be put online shortly after this webinar, and all recordings will be available through YouTube, Facebook, and our website. I think we can end the poll. We have almost 70% of people answering our poll, and as you might notice, the results are completely different by the beginning of our discussion, and we evolved with almost 90% of people now feeling comfortable. They have sufficient information to safely restart courses, and 83% of people who intend to shortly restart them. So many thanks to all of you, our big ERC family, to have answered those questions. Before we close our meeting, I will go back to John and ask for a last take-home message for our participants.
Thank you, Nicolas. I think the thing I would say as a take-home message is to remember that newborn life support has not fundamentally changed. The approach to newborn life support is the same. The likelihood of a newborn baby having COVID-19 is very low, so it should not be the case that resuscitation is delayed unduly because of that. And the final point I was going to make regarding courses, because we didn't have the opportunity to discuss it, was that as far as the newborn life support course is concerned, the course is very similar. There are 1 or 2 slides within the lectures, but the rest of the course is essentially unchanged apart from acknowledging the concept of PPE during the simulations. The airway test is unchanged and the MCQ is unchanged. So hopefully people will feel confident enough to reschedule NLS courses, and we will be putting resources up on the ERC website to help people with the organisation and the timetabling of those courses with additional resources.
Thank you, John. Patrick, one last take-home message for our audience.
I don't know if you see my screen, but actually I could talk a lot, but it's a balance. What we know is that children are low spreaders, but that things that would generate aerosols like airway and breathing are actually the things, if you manage them, that save lives. And probably the latter is equally important.
Thank you, Patrick. Carsten.
Yes, so going back to my picture, showing the courses we already did. Oh no, so wrong screen, sorry for that. So I'm going to stop that. So it's important to restart the courses as soon as possible because we take care for the patient in cardiac arrest that are not affected by COVID. And on the other hand, we need to practice, we need to train for the COVID situation. Yeah, so take home is started as soon as possible. Your candidates are asking for it and it's needed for the population.
Carsten, and then I move on to Tino.
A lot of people are asking very specific questions, and I can tell you we will continue this form of webinars and addressing either specific course formats or questions for training educators. So stay tuned with the ERC and you will get this information. And we are testing out this format. So Carsten told you already he did a 2-day course. We in Bernware are going to do 1-day courses with 1-day e-learning, and we will evaluate this and hopefully publish as soon as possible these results so you get information how this type of courses are going to work.
Thank you very much, Tino. And last but not least, Jerry, anything you'd like to share in a take-home message with our community?
Thanks, Nicolas. Well, most importantly, I want to thank all of the speakers this evening for their efforts and their time in, I think, producing an excellent webinar, which I think a lot of people will find, in the main, very reassuring in terms of getting courses back online. We all know that the COVID-19 pandemic is rapidly evolving, almost by the week, and at different times in different countries. And I would hope that we could now work towards getting our resuscitation courses back online, but understanding that you will need to work with your local authorities, local hospitals, etc., to work out a way that makes those courses safe so that people will be very happy to come along and be trained, and that the instructors will be happy to deliver the training. So thank you all very much, and let us hope that courses will get back up and running very quickly.
Thank you very much, Jerry. Thank you all for participating. I'd just like to do a final thank word to our staff and CEO Olivier but also our office staff and Iliana, who are working behind the screens to make sure that our webinars were working technically, and many thanks to them as well for their support, and for you to attend this first ERC webinar. Stay safe and have a nice evening, everyone. Bye-bye.
Bye.
Bye.